Hi, welcome to House Call. I'm Dr. Brian McHugh. Today I'm speaking with Nurse Penny. She is a hospice nurse living in the Washington State area off the grid in a cabin. And she's very focused on education around end of life and hospice services. You may know her from social media, where she is a prolific content creator discussing the very difficult topic of end of life, how to deal with death, how to accept death, among a host of other issues. Our conversation gets into her work, her upcoming book, Influencing Death, and a whole other host of fascinating topics. I hope you enjoy the conversation. I definitely did. There's a lot to learn from someone like Nurse Penny. And now I bring you Miss Penny. Hi, Nurse Penny. Thanks so much for doing this. Thanks
Hi,
for putting the technical challenges.
thanks for having me.
Absolutely. Um, so I think, my team, we've put together this podcast over the past several months, just almost as like a passion project kind of thing we're doing on the side. I'm a neurosurgeon in practice, and it's just been a great opportunity to sort of see what people outside of neurosurgery are doing and have some interesting conversations along the way. And I think our team, I know Suzanne, who works on my team, was following your content for a while and was just really impressed with everything you're doing. And unfortunately for us in neurosurgery, we do see death quite a bit, and that's unfortunately kind of a daily experience for us, for better or worse. And so we thought, reaching out and having a conversation with you would be super interesting. I know in my own practice, it's something I've grown more comfortable with over time, having open conversations with families, and I think it's really helped the patients I come into contact with, because when we're dealing with end of life situations, it's not helping anyone to beat around the bush and not address the elephant in the room, if that makes sense. And then
Yeah,
to
absolutely. It makes sense.
and to not have frank conversations, I've learned over time also is not helpful, right? Because there's so much emotion in that moment that anything besides direct language is typically, in my experience, misinterpreted. Um, so I guess maybe to start, how did you choose hospice care? Like that, I think a lot of people would think, oh my gosh, that's, really kind of God's work, but how could you do that every day and not, burnout, I guess would be the right word. Why did you choose it, and how do you manage that?
Well, first of all, I just want to acknowledge what you said about frank language because you're singing my song right there. In fact, I'm working on a speech that I'm going to be giving, and just today going through it. And a major part of my speech is talking about how we should not be using euphemisms when we're talking to people about death and dying because they're so emotional that sometimes they can't see the forest through the trees if we're not being very clear. So just wanted to put that out there.
Yeah.
But to answer your question, so first of all, I became a nurse when I was in my 40s. I went to nursing school at age 40. And what drove that was a divorce. I needed to have a career.
Yeah.
And a couple of years prior to going to nursing school, my stepmother in law got cancer and died in a hospice care center. Well, she was in a hospice care center and then she went home on hospice. And I was just so impressed by the nurses. They were
Mm.
so compassionate and kind, and but also just really smart. And when I decided to go into nursing, I wanted to pick a field where I felt like I was truly going to be helping others. Not
Mm.
that all nurses don't help people, because
Right.
that's what we do, but I really wanted to have a role in nursing that I felt was meaningful. Um, Selfishly, to make up for the sins of my past, because there's a reason I didn't go to nursing school until I was 40. I was a late bloomer and I was in a lot of trouble as a younger person. And so kind of just wanted to do service work. So
Yeah.
I decided that it was going to be either working in a nursing home. At that time, there was a lot of stories about abuse happening in nursing homes. And so I thought, I can make a difference by working in a nursing home or being a hospice nurse. And
Mm.
I went to work at a clinic when I first graduated, because you can't really dive right into hospice as a new grad. But I went to
Okay.
work in a family practice clinic. And then about a year into my nursing career, there was a hospice care center opening up in the neighborhood. So I transitioned to a hospital and I worked there for about 3 months. Now, I started as an LPN, and I didn't know that LPNs could work in hospice. I thought you had to be an RN, and I was on the pathway to be an RN. But in the meantime, I figured I should go get experience in a hospital so that I'll be ready to work in hospice when I become an RN. Well,
Mm.
hospitals do like this cyclical layoff with LPNs, and I hit the cycle. So 3 months after I started at the hospital, I was laid off. And I thought,
Mm.
well, I'm going to go to that hospice care center and I'm just going to ask and see if they hire LPNs. And sure enough, they did. And
Yeah.
it was amazing. I did that work for about 7 years before I transitioned to home hospice. And I always say it was at the bedside, in your face, death and dying. It was such a good experience for me to really wrap my brain around end of life care and the death and dying process. I had no experience with death prior to that. I had never seen a dead body, and
Mm.
so it was going into it completely blind. In nursing school, they don't teach you very much about death and dying.
Oh.
We had about an hour lecture on hospice, and that was it. So it was such a great experience, and people do say it's a calling, it's God's work. I always think that's a little bit trite. For me, it was a way of redemption, if
Mm.
you will. And the other thing people say about hospice is that it must be so sad. It must be so sad, and the burnout factor, like you get burned out. And to be truthful, I did burn out. I've been a hospice nurse for 20 years, but for about the last 7, I've been working in hospice education and quality. But I wasn't
Mm.
burned out because of the patients or the families, which can be
Yeah.
very trying sometimes. It was the commute for me that finally did
Yeah.
it. I was a home hospice nurse in Seattle, and I just had to get away from that commute, and I was offered a virtual position. But I know hospice nurses who stay at the bedside for 20, 30 years.
Yeah.
If you are able to uh, mind your boundaries, your
Yeah.
emotional as well as your professional boundaries, do your work, not take it home with you. Don't get personally involved. Understand that you're there to do a job. That's not your person dying. That's not your family. You're there to help them. It's not about
Yeah.
you. Then you can stay in it forever. But
Yeah.
as soon as you start to, you know, get too emotionally wrapped up into it, then that's what causes burnout for people.
Yeah. Agreed. Agreed. That's a great jumping off point to some degree. What on the surgery side, I've found kind of two types of, well, I guess three types of practitioners. The folks who invariably get emotionally bound up in it, which tends to come with an early retirement because they quote burn out. Folks
Mm-hmm.
who are clear in their mind, oh, I can't take this home with me. It can't become too personal. So they dehumanize the patient to a degree where they're not compassionate. And then the people who've struck a balance. What techniques did you develop to strike that balance? If you agree even with that assessment, I guess.
Yeah, yeah, I think that makes sense. I definitely did not do the dehumanization path.
Yeah.
um, because you have to have compassion and empathy to be a really good hospice nurse. You
Yeah.
have to be able to, really, not be afraid to kind of get into it with them a little bit emotionally, but still, it's a fine line. You definitely have to walk that fine line and to just really remind yourself that you are there to do a job and care for that family, and you have to be able to keep it together so that you can continue to help them. one of the things that I did was I didn't go to funerals for my
Mm.
patients. I've known hospice clinicians who say, I go to the funeral of every patient. I worked in a care center and we had dozens of patients dying a week, several
Yeah.
in one shift. You know, if I was to do funerals, that's all I'd ever do in my free time. And so,
Yeah.
because I really want to have that work life balance, I was like, no, I am not going to go to funerals. I'm just not. I made exceptions only twice. One of them was actually my husband's great aunt came to our hospice care center and was a patient, so I felt kind of obligated there. And then
Yeah.
another one was just a young woman I'd done continuous care with at the home. We did palliative sedation. She had two 20-year-old daughters. I got very, you know, I wouldn't say attached, but I, had a really good rapport with her daughters and her parents. And it was a kind of a journey that we were all on together as we were trying to manage this young woman's, extreme pain and existential suffering and terminal agitation. And, and that was one where afterwards you're like, oh, I need to take a day off. And that's important too. There were times when I had to just say, I'm not going to work today because this person who I have been, in the trenches with as he is dying, and it's been a really tough case, he hasn't died yet. I'm on vacation at my cabin. I've said goodbye to him. He was at the hospice care center, on a higher level of care. He was going to die soon, and I knew it, and he knew it, and we said goodbye to each other. And I went on vacation for the weekend to the cabin and checked my email. So here's where I crossed the line,
Yeah.
right? I'm
Hit the
checking
line.
my checking my email to see, checking my work email to see if he's died yet, and he hasn't, and called in and said I can't come to work today because I'm not going to do it. I cannot go back and see him. And then he did die that night. So
Yeah.
there are times when you have to do what you have to do to survive, but um, it's just I always say if you want to know if you are crossing a boundary with your patient, you ask yourself, would I do this with any of my other patients? And if the
Hmm.
answer is no, then there's a good chance that you're crossing a line. So as it was,
Yeah.
I did check the death list for all my patients when I was off the weekend, just so I knew what I was walking into Monday morning. So, you know,
Right. Do you, for some reason, that just struck a chord in my brain? I always find myself struggling more as a practitioner. If it's an elderly patient who's lived a full life, I find within myself like a certain ease in moving through the conversation with the family because somewhere in my mind this person was granted a full life, had hopefully lived it well, and this is really kind of a celebration of a long life lived. Even if the family's kind of struggling with it, like personally I'm more at peace with the conversation as opposed to someone young, or especially someone who you can identify directly with, someone who would look like me or be my rough age. It sort of makes it much more personal. If you've also noticed that, do you have any advice for people on how to keep that compartmentalization going when there's not an easy mental rationalization, right? If the patient is 92, I feel like in my own mind I can say, look, this is nature's course, and they've lived a long life. If it's I'm 46, if it's a 46-year-old white guy, it really hits home, and kind of maintaining that equipoise and compassion is not not harder, but it just makes it a lot more emotional on my end.
hmm yeah, definitely. I think it's a slippery slope to kind of, I mean, if it helps with your conversation to be able to do that, that's good. But one thing I've always, as I've grown up in hospice, the older I get, the younger old seems. And
Yeah.
so I think when you're talking with somebody and they're elderly and you're thinking they've lived a long life, I sometimes will think, well, my mom is 85 years old and she's okay with how long she's lived. She's got her pulsed and she's a no code and but she's very healthy, and
Hmm.
so for us, yeah, she's 85, but she's still
Good
really
point.
young to us, and
Yeah.
she's our mom,
Yeah.
so I mean, having the conversation can be hard with anybody. So for me, and I totally get what you're saying about identifying because I've had that situation too where, the patient is the same age as my son.
Mm.
I really relate to the mom.
Yeah.
Talking to a younger person about death and dying is going to be harder, and we
Yeah.
do have to do that in hospice because unfortunately the reality is sometimes they don't get that conversation before they're referred to us. They're told that they're going to go to hospice where they can get more help. Not
Mm.
that they're dying or that they have
Right.
a year left instead of 6 months, which is, the eligibility requirement. But for me, I
Right.
think I mean, it's hard, but just understanding that death happens to everybody, and we just have to accept that. And it
Mm.
sucks when it happens to people who are young. It does. But to be able to have those conversations with them is the most compassionate thing that we can do, to
Mm.
allow them to know what's happening, to allow them to grieve their own end of life, to give them
Mm.
the opportunity to say goodbye to people so that they know to check off their bucket list, to do the things they want to do. And I think that's what I think about when I'm having to talk to somebody about the end of their life is, that not so much you've lived a long life. It's, which, and I'm not suggesting that you say that because I know you don't. I get what you're saying. It's like in your mind, it's easier to have that conversation because
Yeah.
it's like it's easier to care for somebody who's 90 and dying than it is to care for somebody who's 28 and dying
Yeah. That's what I meant. Yeah. That's
because
kind of what yeah.
you're like, ugh,
It's a,
they're so
you make
young.
you make a good point though. So, and I don't know that I've ever directly used that language. I feel like the family may say something like that, and you can reflect it back to them. But it's a good point if the patient's there and saying, "That's not how I'm feeling." I'm not feeling like a ton of gratitude for dying. I'm feeling a lot of grief over this. I guess your advice would be you really don't want to kind of openly use language like that just because of someone's age. Like that's not necessarily the right
No,
path.
I
Yeah.
I think we need to use the language. I think we need to tell
Oh, okay.
somebody that they're dying. Absolutely. We
Oh, I
don't,
meant I meant
yeah,
that sort of
because
framing it like, oh well, Penny, you're 94. This is great. You made it to 94. Long life lived. Congratulations. Like, would you
yeah,
shy away from? Would you say I wouldn't go in that direction with it? That's you don't want to
yeah,
put it that.
I would, yeah, I wouldn't, unless they're leading the conversation with that.
Yeah.
If they're
Yeah.
saying, well, I've lived 94 years old, of age,
Yeah.
I'm happy, then that's fine. But I think for us to assume that,
Hmm.
so we had a patient one time that came to the hospice care center who was 92 and
Hmm.
he had fallen while he was ballroom dancing with his wife, who was, I think, 15 years younger than him, and broke his hip.
Yeah.
And he went to the hospital and they wouldn't do surgery because he had a cardiac condition and he was 92 years old. And he came to
Hmm.
the hospice care center and he was livid. He was
Hmm.
so mad. It's my choice. I should have the choice. I should have the right to have the surgery if I want to. And we're all thinking, dude, you're 92 years old. Come on. But also he has a heart condition and the surgeon doesn't want to have his death on their hands. They don't want to do surgery on someone and have them die on the table. But he was so mad and his wife was so mad, and
Yeah.
I could kind of get it. And he actually signed out of hospice and went home. He was like, I'm going home. I'm
Yeah.
like, okay, went home with this broken hip,
Yeah.
but it it was like, okay, he was ballroom dancing when I can see, you know, and also, it really depends on, I think, the person's health to the point they get there, how
Yeah.
healthy they are at the time that they're diagnosed. I was just talking with my friend who's a social worker, hospice social worker today about how the things that we do to people with dementia to prolong their life and how it just
Mm-hmm.
seems so unnecessary.
Hmm.
what are we doing? Their quality of life is terrible. Why are we going to now put them through dialysis because they have renal failure?
Yeah,
I think it really depends on what's going on with that person.
that makes
But yeah,
sense.
I would say you don't open with that. You let them.
Yeah, leave that conversation. Well, it brings up a good point as we all get older, at least that's my experience has been, granted, I'm healthy right now, knock on wood, but I still feel 25 in my mind. And I could imagine if I remain healthy, or maybe even if I don't, it's very hard to project what your inner self will feel like, quote unquote, if I'm lucky enough to make it to my 90s. But I could imagine sitting there and still feeling like I'm 25 in my brain. It's just this body, and not wanting to hear about, of course, this is the end of the line, Brian. What else did you expect? Say, well, wait a minute. No, no, I'm not. That's not how I want to end this. I'm healthy. What are you talking about? I could see that. Or to your point, if instead I had struggled with whatever disease for a number of years, maybe I'm more than welcome of a conversation reflecting on how long I've been alive and how good of a life I've led. Um, and one thing that just came into my mind based on what you said, Penny, do you find, like, I've noticed with patients, some people are very introspective, right, and think about their existential um, framing throughout their life. Maybe they're very philosophical or they're maybe very religious. And then some folks don't. Like there's not a lot of introspection. It's not how they would choose to spend their time thinking. They're more in the moment. Do you find with patients that that matters when you're having an end of life conversation? Maybe another way of putting that, for people who have a lot of angst and are fearful of death for their life, for extended years, are they more accepting at the end than someone who says, I haven't thought about any of this. I don't think like that. Have you noticed anything like that?
Well, it definitely impacts the conversation, when people are not haven't ever thought about it and don't want to talk about it. There's the people who haven't ever thought about it because they're okay with it, and they just, like my dad, he was
Yeah,
like, when time came, he was ready. He was like, okay.
yeah,
I don't think he never talked about it. I don't think he gave it a lot of thought. Then there's
right,
those that they think about it a lot, and they get to that place where they're like, yeah, I'm okay with it. And then there's
yeah,
those that don't want to talk about it. They don't want
yeah,
to think about it. It's not real. It's not going to happen.
yeah,
Those are hard conversations.
yeah.
And those can be really hard deaths because
Uh,
those people can have terminal agitation. When they have existential suffering, existential crisis, because they haven't ever gotten to a place of acceptance before their death, they can have terminal agitation. And then, unfortunately, we usually have to sedate them until their death because they're so
yeah,
agitated.
yeah,
But I will say that many people do get to a place of acceptance before their death if you give them a chance, and
yeah,
that is being willing to talk to them about the fact that they're dying. So
yeah.
I want to give you an example of this. There was a young woman on TikTok who had colon cancer. She was in her early 40s, I believe. And she made a video crying about the fact that she had just been told she's going on hospice. So now she's dying and she's terrified and she's crying. And that video got 10 million views on it. And people were tagging me in there right and left, like, Hospice Nurse Penny, what do you say about this? And I said, well, I say that there's nothing that we can say to her that's going to make her feel better about it. She is dying and she knows that now, and she needs to process that and work through it and accept it. And little by little, she starts making videos about the things that she was doing on her bucket list. She
Mm,
wanted to have beignets. She said it was something that she's always heard about and never tried. And so there's
mm,
another TikTok creator who had a food truck who was a beignet baker. And
uh,
he raised money through a GoFundMe, flew to where she was. People sent her Mardi Gras decorations, and he
mm,
made beignets for her, and she had a living wake. And so
yeah,
you see this change in her from I'm terrified I'm dying to
yeah.
I'm accepting I'm dying.
Yeah.
and having a peaceful death with her friends and family at the bedside because she accepted it. So it's
Yeah.
so much better for people when they can accept it.
Yeah.
But they can't accept it if they don't know it's going to happen,
Right. Yeah.
and
Not knowing it's
sometimes that
gonna.
conversation is hard if they don't want to hear it.
What do you have maybe I should know this, Penny, but do you have a stance on, I don't know what this question is. Like, do you get religious with folks if they want to get religious? Do you get philosophical with people if they choose that direction? Or do you say, look, that's not my role. I'm here to kind of deliver hospice care and clinical information. The bigger questions in life are for, your priest, if you have one, your imam, your rabbi, whatever your personal spirituality is, or are you, you know, listen, I'll talk about anything. How do you deal with that?
You know, a little philosophical maybe can have conversation around that, but if we're really diving into especially spiritual or religious, that's not my role. That's the role of the hospice chaplain. And
Hmm.
so if somebody wants to engage in a religious conversation, then the chaplain is who I will say I'm going to have the chaplain call you, because that they have a master's degree in divinity. That's what they do. They are schooled in every kind of religion and spiritual belief that there is. That is literally their expertise. It's not
Yeah.
mine. And I would certainly never bring religion up to a patient that is proselytizing, and Medicare is like, no, you don't do that. We are not allowed to proselytize. We are not allowed to try to get people to go with our religion,
Right.
because we are taking care of people from all all types of religion and non-religion. And
Yeah.
so as a hospice nurse, you know, um, if somebody's like wanting to talk about philosophical things and I feel comfortable with that, then yeah, I will. But I'm
Yeah.
not comfortable talking about religion because I'm not religious. So I
Yeah. Yeah.
wouldn't, if somebody wants me to pray with them, you pray, I'm here, I'll pray with you. I've sat in on Buddhist ceremonies, and
Hmm.
for sure will honor their religious belief if I happen to be present at the time that that's happening.
Yeah.
But it's not my role to bring that to them or to try to counsel them for that.
From that, yeah, yeah, I would say that. Not that I don't think I've stepped in that to this point. The only, I don't know, I haven't gotten religious, but if they want to speak in that language, I'm happy to listen to them talk. But I'm not religious either, so I don't offer anything back, and that's never gone terribly awry in talking with patients. But I think it is a line where staying in your lane as a practitioner. I'm not an expert in divinity of any kind, so I don't want to be, you know, miles deep on that conversation by any means, and nor should I be. Kind of how I
Yeah,
view
and
it.
same with politics. Politics is off limits,
Right. Yeah, not a good idea.
especially these days. It didn't used to be so bad, if somebody
Yeah,
brought politics up, especially if it's mine. But
yeah.
nowadays
Don't do
it's
that.
too
Yeah,
hot of a topic.
don't go there.
Like, let's not talk about politics right now. You don't have much time left. Let's talk about something that's more important to you.
Very fair. You've written a book, right? A new book. Am I getting the title
I
right?
have
Influencing Death.
Influencing Death, Reframing Dying for Better Living. Yeah,
Yeah.
it's
Is that
it's going to go up for pre-sale towards the end of October and be released
okay?
in January.
Okay. And um, and if people wanted to buy it, Amazon, where would they? What's the right place to go
Yeah,
to get that?
sure. It'll be on Amazon for sure.
Okay.
Amazon or wherever you get your books from. Hopefully, it'll
Yeah.
be in Barnes and Noble stores if I'm lucky and they pick it
Nice.
up. But yeah.
Yeah. And what was your? Why did you write it? What made you sort of say, I'm gonna write something?
Well, my mom used to tell me when I was younger that I had a book in me. She'd always say, "You've got a book in
Oh,
you,"
yeah.
just because I lived so many different things in my life. I experienced a lot of stuff in my life.
Yeah.
I always say I was to the 80s what hippies were to the 60s. Uh, but when I got the TikTok platform and realized, and so I've really been passionate about end of life education and hospice education. It's just something that's a passion of mine because for one, I just really believe in high quality end of life care and that accepting that we're going to die is important. And I used to have death anxiety when I was younger and found that by getting to that place of acceptance of death that was relieved for me. So being on TikTok and basically influencing so many people to think differently about not only how we die but how we live just really prompted me to write a book. People are inspired by the things that I tell them. I have lots of people who say, I'm 40 and I want to be a nurse, but I think I'm too old. And I say, I was 40 when I went to nursing school, and I share my journey in recovery. Just lots of things about my life that I think can be helpful to other people. And the feedback that I get from the people who follow me on my social media tells me that I am helpful to them, that I have helped them.
Yeah.
And so I just wanted to kind of finally pay attention to what my mom said because I never did for so many years and put it all in a book.
Yeah, that's what I was going to ask you. Is it sort of a compendium of all the energy and information you've put out on social media? Like, what has that been sort of a framework that you at one point said, you know what, I think I can write this all down. Like, I think I can put this in book format.
Yeah, I actually started writing it before I got on TikTok, but
Oh,
it's a memoir and it is a compilation of the different things in my life that I do address on TikTok and
yeah,
then some. It talks about, my early life, being bullied, being a drug addict, going to jail, giving my child to his dad to raise, and then turning my life around. And I do kind of there is like a loose framework of my TikTok journey as
yeah,
well, because
yeah.
kind of starting out with like I was basically 59 years old or 58 years old when I got on TikTok,
That's what I was going
and
to ask you next. I was going to say, how did you, when did you get on social media and what like prompted that? I mean, obviously we're doing this, but I'm not totally on social media. And as someone who's not of the, I don't know what the right phrase is, wrong or right generation for social media, or I'm not a Gen Z or where you grew up with it. It feels different to me to be on social media. You, where you are, like that was going to be my question at 59, I guess. What prompted you to get out there, and did it feel awkward since you didn't grow up with the internet?
do you remember what you said a little while ago about what you are in here age wise?
Yeah,
That's me.
yeah,
I'm not, I mean, I have a 62-year-old body, but in here,
yeah.
I don't like to put myself in my 20s in here because I was really screwed up in my 20s. I would
Fair
say
enough.
more like I'm in my 30s right here, right? But
Nice.
I for one thing, I like to buck the system too. So I'm a boomer, and boomers have bad reputation. And like, what are you doing on social media? You're a boomer. So I don't.
Yeah,
No, it doesn't matter to me. Age is just a
yeah,
number. And I got on TikTok during COVID, like everybody else,
yeah,
and I started doing like some of the dumb trends that were on there that had nothing to do with being a nurse or being
yeah,
a nurse that takes care of dying people. Tried learning how to shuffle dance. And
yeah,
then I don't know, one day I just thought, you know what, I'm going to tell a story about a patient that I took care of who was dying. And
yeah,
it went viral. And
yeah.
I was like, oh, wow, people want to know about this. And people had so many questions. I
Right.
just had tons of questions. And I've always been a little bit of an entertainer. I used to sing in a rock band, did
Ah,
stage, acting and stuff when I was younger. And so I just really was, really liked the trends that they do. And I would take little, 15-second or even 8-second song trends that you lip
yeah,
sync to and you put words on the screen. And I did one. There was a song that went, "It's just water, it's just water," and so I'm lip syncing to this song. It's like, I don't know, 8 or 12 seconds long. It's really short, and then
yeah,
I put up the words on the screen. Your person didn't die from dehydration; they died from their disease. It's something
yeah,
like that. It's like some. And this woman said in my comment section, "Thank you so much. For the last 15 years, I have had so much guilt over my dad's death because I didn't ask them to give him IV fluids
right,
at the end
right,
of his life." And I was like, wow, like
yeah,
lip syncing to a song for 10 seconds and putting words on the screen literally changed this woman's life. And I
right,
was like, I am onto something here, you know? So, and then humor too, I love using dark humor. I always say
yeah,
lightening up the topic of death. Death is a dark topic. Let's lighten it up with humor. And that just really reached a lot of people. So there's humor in my book too.
yeah. Oh, nice, nice. Yeah, I guess I meant it as like the question was kind of, I'm not a writer at all, but I could see how doing what you do on social media like would help formulate the memoir in your mind, if that makes sense. As opposed to someone who does what you do, you're on social media, you're working, and you say, as a total side project, I'm going to write a book. It doesn't seem like it's a different thing, really, the way you do your social media. I could be wrong. So that's kind of what I meant by the question. Is
Well,
there?
social media gave me the topics that people find interesting and important.
Yeah, yeah. And I guess it's almost like it's probably the wrong term, but like voted on in real time. I would imagine like you have that view through the social media lens of where people are engaging. I would imagine,
Hmm.
and you're able to realize, oh, these seem to be the topics that people are really interested in because there's a lot more engagement there. Is that an accurate like description of
Oh, yeah.
your view of your audience? Yeah, yeah,
Yeah, definitely. People, well, there are certain topics that when I talk about them, it's almost sure to go viral every time. Deathbed visions is one. People love knowing about deathbed visions.
oh wow,
The
yeah,
end of life rally, when people have a burst of energy at the end of their life,
yeah, yeah,
that type of thing. So I definitely know what grabs most people,
yeah.
but I also know, what's important when you are teaching about death and dying that should be included, even if maybe the videos have never gone viral. You really have to put it into perspective. When you grow on social media, at first, when you get 1,000 views on a video, you're like, 1,000 views,
Yeah,
and then as you grow, you're like, oh man, 10,000 views, that's all I got, or I didn't even hit 10,000 views on that, or, like
right.
it, you have to remember. And so I try to remind myself, like, if I was in a room talking to people and there were 300, 400 people in the room that liked what I said, by liking my video, I know that they like what I said. That's a lot of people, you
Yeah,
know.
a lot of
So you have to
people.
remember that.
Have you figured
It's a
out like
numbers game.
is there some like you mentioned making which videos would grab a lot of views. Has there been a piece of information that you felt like you wanted to communicate to people that you knew wouldn't get the same traction on social media and given your experience were able to package it in something that would get a lot of engagement, if that question makes sense?
Yeah, it makes sense. So people are probably not that interested in whether a person going on hospice can have a full code or not. It's like
Mhm.
probably not like widely, probably people don't give that a lot of thought.
Yeah.
But when I do a trend video that's a little bit more sensational, that
Mm-hmm.
catches their attention.
Uh-huh.
And then I'm able to then follow that up with another video that talks about, yes, people can be a full code when they come onto hospice, because people will ask me questions in the they'll be like, wait a minute, they're on
Right.
hospice. Why are they a full code? And then I can
Right.
answer that question and say,
Yeah.
because we're allowed to bring people onto hospice that are full code. So that's how I frame something that I think is not going to be as interesting, or something that might be a little bit a topic that might be a little bit more sensitive, or that people are going to be, like not want to not want to accept as much, like that hospice starves patients. People want to say hospice starves patients, and so um, I'll do something, or like, here's one. So people who don't want their person who has lung cancer to smoke a cigarette when they're on hospice.
Mm.
That's something that not everybody is going to be that interested in. But when I make a video that's more sensational, saying lighting a lighter for a hospice patient, which we don't do in real life, but
Right, right.
it kind of grabs their attention, like, wait, what? People can smoke when they have lung cancer and they're dying?
Yeah.
Yeah, sure they can.
Yeah.
Why not? What's it going to
Yeah.
do?
Yeah, right. And I want to be mindful of your time, Penny, but I wanted to ask, like, get into one other topic if you're okay with it. That's like kind of the euthanasia discussion. I'm not trying to get political or anything. Just how I don't really deal with that in my line of work, but on the hospice end, well, that's not true. I mean, we see it plenty with end of life situations and questions from patients. Do you take a firm stance on it, given your work? Maybe rather than like making it a political discussion, I would just say, given what you see every day, how has that informed the way you would react to that?
Yeah, so just for a point of clarification, there's no state in the US that it has legal euthanization. Euthanasia is when a person gives a medication to a person to end their life, and we don't do that anywhere in the US, but there are 10 states in the District of Columbia where death with dignity laws are in place, and that is when a person who is terminally ill with a life expectancy of 6 months or less has been found to be of sound mind,
Hmm.
um, and has established that is their choice and there's no one coercing them, are able to self-administer prescribed medications to end their life safely. I am all for it. I've always been all for it. I've never met a hospice clinician who wasn't all for it. You know,
Interesting.
on a whole, hospice will say, some hospices, especially Catholic organizations, will say, we don't believe in it because we think hospice can help people at the end of their life. As a hospice nurse who has done palliative sedation on numbers of patients because they had existential suffering at the end of life, and in my mind, I think, what's the difference if we're sedating them until their death? There's
Yeah.
still no quality of life there. I believe in bodily autonomy. I believe in choice. There are things worse than death.
Yeah.
Most of the people I've seen die have had a peaceful death at the very end, but sometimes getting them there is not a smooth ride at all.
Yeah.
The body can turn on us in ways that you can't even imagine.
Yeah.
To
Yeah.
have to be stripped of all your dignity by a cancer that just rots parts of your body. You know,
Yeah.
I, I'm all for it, and it's legal in my state. I would absolutely do it if I had, if I was terminally ill with something that I thought was going to be really causing devastation to my
Yeah.
body or my emotional self.
Yeah. Yeah.
I wish it was federally legal. I think that I understand why there are certain rules in place, in which unfortunately preclude some terminal diagnoses. Like if you have dementia, you cannot
Yeah.
do death with dignity. And
Oh.
instead, those people have to resort to VSED, which is voluntary stop eating and drinking. And so
Yeah.
they have to leave some life on the table because they got to do it early enough when they're able to still do that. But
Hmm.
also, when people don't have that option available to them, or if it's not accessible, they will take matters into their own hands. And that is so much worse, so much more traumatic. There's a possibility that they're not going to die with whatever method they try to use to end their own life, and they're going to
Yeah.
be in worse shape than they were to start with. And unfortunately, in my experience, there have been patients who were unable to access it. For a while, the price of the medication went up very high, and people couldn't afford it anymore. And,
Hmm.
we had a patient who hung herself in the bathroom at the hospital. We had a
Yeah.
patient who shot himself in the head. We had a patient who overdosed on his long acting morphine. So,
Yeah.
we have had patients who died by suicide because they could not access death with dignity, and
Right.
that's so much more tragic to me.
Yeah. Yeah. And the other thing I would imagine, I don't know if you see this, but if you're, when it's not legal, quote unquote, you may get folks kind of making that decision on their own without the appropriate information. Perhaps their condition wasn't as terminal as they thought, or um, yeah, I guess that's kind of what I would be thinking of. Someone who says, "Oh, there's no legal way to go do this, so I'm not getting access to the professionals, and I'm not getting all the right information." So it seems like there'd be a cohort out there who said, "Oh my gosh, this is a terrible situation. I'm going to just end it myself." And you said, "Whoa." If it was legal, they would have come in through the proper channels, and folks, professionals, would have said, "You don't need to do this right now. Like this isn't necessary right now. You can do it in a more timely manner, in a better way." So it just seems like we, as a culture, we just haven't come to grips with the end of life, even though it's part of the whole, not to be trite, but it's part of the whole cycle of life. It's part of living is dying, and we don't really culturally accept that to some degree, and arguably even in the medical system, right? Kind of Western medicine, part of the
Mhm.
canon is like we're battling death, but sometimes you're not battling death. That's part of life. So I guess I couldn't agree with you more. But Penny, thanks so much for your time. I don't want to take too much of it. One other question. Sorry, this came up earlier. Suzanne, who works with us, was saying, do you live off grid? Are you like, is that your permanent residence? You
Yeah.
mentioned your cabin, so I'm assuming it's
Yes.
not your permanent residence.
It is my permanent residence.
It
Right
is.
now,
Okay.
I'm in my studio, which is an office space in the medical building in the town of Curlew, which is where I live. A population, I think, 86 or something like that.
Oh,
But
wow.
yeah, my husband
That's,
retired, and my job is now virtual. I work 3 days a week. I had to cut my hours back because of my social media. I'm on the retirement pathway myself, and we
yeah,
live in a cabin up on the mountain off the grid. We do
that's
have, though
awesome.
people always say, well, if you're off the grid, how are you doing social media? Well, we have a Starlink satellite, and we have
Yeah,
cell service up there.
yeah,
So, we are able to, it's not completely prehistoric. We don't live in a
yeah.
cave or anything. We actually, when we first moved up, had an outhouse and no running water. And now
That's
we do. So now we have a toilet and a shower and hot water and all of that. So we've moved up in the world. But
how
yeah,
did you
it's
how did you
amazing.
choose that location? Like what? I mean, not
So
just a specific spot. Like how did you choose that part of the country?
my husband lived in Eastern Washington when he was younger, and we wanted property over here. So we lived on the west side where Seattle is, and we wanted to buy some property over here that we could just camp on. And
Yeah,
we bought this piece of property, and little by little, we built the cabin and expanded our property, bought more and more, and just decided that it's just a beautiful, peaceful place to live. I was just really, really sick of the rat race,
yeah,
in the city. Just both of us were just really wanting to get away from that and live up here as long as we can. And we know that we probably aren't going to be able to live this way forever. And he's 65, I'm 62, and
yeah,
we are kind of, as we go along, making it more and more convenient. But I always say, people will ask me on my social media, um, you know, how do I think I'll die, or how do I want to die? And I always say, well, I want to die really old in my own bed in my sleep.
Yeah.
But I think I'm going to die by falling down the stairs in our cabin because we have extremely steep stairs. It's almost like a ladder. I have to go down backwards from our upstairs where our
Yeah.
bedroom is to the downstairs. And I always say, I know that's going to be the death of me. That's going to be my end. I'm going to fall down those stairs someday and crack my head
Yeah.
open, and that's going to be all there is.
Not the most peaceful way to go.
Well, actually, though it is, I mean, you are a neurosurgeon, so
I
you
know.
operate on the people that have those brain bleeds. My aunt was in her 90s and she was starting to get dementia, and
Yeah.
I think she was 93, and she went for a walk and she fell and hit her head on the sidewalk, ended up in the hospital, died a day later.
Yeah.
Not a bad way to go.
It's not. It's really not.
No,
um, Penny, thanks so much. Thanks for doing this. Really appreciate your time. Really appreciate your willingness to come
yeah,
out and talk. Um, Good luck with the book. I hope it's a smashing success and
thank you.
everybody can internalize its message and your journey.
Thank you so much. Thanks for having me. And people can find
Absolutely.
me on all the socials at Hospice Nurse Penny.
Perfect. My privilege.